All right, and one more. This was actually a medical malpractice case. This patient had bariatric surgery, was advised to go on a wide variety of vitamin supplements because, of course, you can have absorptive alterations when you have gastric bypass surgery. So this patient was told to take thiamine amongst many other things and failed to do so and developed Wernicke encephalopathy in a relatively short period of time. It was only about 3 months post-op that she started having mental status changes. So this is Wernicke encephalopathy. It often involves that periaqueductal gray and the medial thalami as well as the mammillary bodies, which are the classic spot. Right, so you can see there is mammillary body involvement, periaqueductal gray, and medial thalamus. So that's Wernicke encephalopathy as an interesting complication of bariatric surgery. All right, so we've been through them all. Obstruction, intussusception, staple line dehiscence, ulceration, ischemia, perforation, afferent loop syndrome, and then a couple of other crazy complications like nutcracker and Wernicke's. And I'll repeat myself, all CT studies of bariatric surgery patients should be performed with oral and intravenous contrast. I really read the referrings, the Riot Act. That's a lot of alliteration, sorry. When I get these, if I get a non-contrast bariatric patient, I call and say, we are just not done until we rescan with contrast. All right, so that concludes our bariatric surgery complications, and we'll get back into a small bowel with a focus here on hernias. So, all right, this is the best one to start hernias with because this is the one that you cannot miss. A closed loop obstruction is a surgical emergency. There is acute compromise of the blood supply to a significant segment of bowel, and this is going to go south very quickly. So you really need to be able to spot the closed loop obstruction as opposed to just your standard run-of-the-mill bowel obstructions. Okay, the things to look for are just like I was talking about in that cicatrization case earlier in the bariatric patient, right? You want to look for that point where everything is coming together. This is a big segment of bowel that has twisted on one focal point where that mesentery is pinching the vessels, both arterial and venous, that supply that long segment of bowel. These closed loop obstructions are almost always identifiable by the signs of bowel strangulation, right? Thickening, hypodensity, and mesenteric stranding. And you can see we've got that in spades here. There's a lot of bowel wall thickening, and look at that mesentery, all in this obstructed area. It's very heavily stranded, right? So you would not miss the fact that this is sick bowel, but if you miss the fact that it's all spun on that one point, you might not call it a closed loop obstruction. These always look like the bowel is just kind of stacking up to me. See how they're all in line there? And that's something that catches my eye frequently and tips me to the fact that I'm looking at a closed loop obstruction. Right? See, everything is just coming together in that one point. You're really not going to see it much better than this. So, closed loop obstruction, surgical emergency. All right, here's another one. It's a little more subtle, but still pretty apparent. You're certainly not going to miss this, though, right? There's obviously intrahepatic portal venous gas, and you know that's not pneumobilia, right? Because it's arborizing in a different fashion, and it's extending out to the periphery of the liver, whereas with pneumobilia, it's typically more centrally located in the portal region. All right, so we have a thick-walled loop of bowel here, and there is extraluminal gas in the mesentery. Little dots of gas. There's, in fact, pneumatosis lower down. So again, it's not something you'd be likely to miss. And here again, we've got thick-walled bowel. And the vessels, when you watch this on the cine, they will twist one way and then twist another way, just routing through some crazy peritoneal reflections and internal twists. And then lastly, lower down, we can see the definitive evidence of ischemia, the pneumatosis. That's probably the source of the portal venous gas. So there's that portal venous gas. No one's going to miss that. Now look at these bowel loops. See how they're all kind of stacked together? Look at all that mesenteric stranding, little dots of mesenteric gas as well. Right? And then lastly, the pneumatosis lower down right there. Okay, now this time through, we'll look at the vessels. I want you to look at the relationship between the SMA and SMV and how they will flip. They spin one direction and then another. They don't definitely appear to be occluded, but this is one where you would want intravenous contrast to say for sure. But you can definitely see how those bowel loops are stacked up. There's clear perforation. There's mesenteric stranding. This is a great appearance for a closed loop obstruction as well. Right? And then the pneumatosis, which with all this activity, it could be easy to miss. But obviously you need to go looking for it because you've got so much portal venous gas. And so you saw the vessels twisted one way and then they go back the other direction. All right, that is another case of a closed loop obstruction. All right, some basic hernias. We'll go through these fairly quickly. Obviously, all of them are going to have associated small bowel dilation, but in this instance, there is a collection of gas in the scrotum. So this is going to be an inguinal hernia, and since it's in the scrotum, you can say it's also going to be an indirect one, which most of these are, certainly especially in infants. They typically get the indirect type, right? Because they just have a congenital patulous inguinal canal. So there it is. It is the easiest thing in the world when someone presents with a bowel obstruction to check that scrotum. When I was an ER doctor, I remember getting a plain film on a patient saying clearly small bowel obstruction. I called the parent hospital to arrange a transfer, and the guy on the other end said, "Well, does he have a hernia?" And I went, So it was pretty embarrassing. It should be the first thing you do. If you're a clinician in the ER and you have a bowel obstruction, you check them for a hernia. If you're the radiologist reading a CT scan, go check the scrotum, make sure they don't have a just standard bread and butter inguinal hernia. And here it is on the coronal, even more evident. You can see it coming down through the canal right there. So that is an obstructing inguinal hernia. Whenever you describe a hernia, they are always going to want to know, is it strangulated or incarcerated? So look at that herniated loop of bowel for stranding, wall thickness, fluid collections, anything that might suggest it's more than just herniated. Okay, this is a great one. This is an inguinal hernia that's causing a closed loop obstruction. So a loop of bowel turned and then a little portion of it herniated. So you can get both at once. And you can see this is a great example. Everything is coming together up near that inguinal region, and you've got bowel dilation, a segment of bowel dilation with mesenteric stranding. So this is highly suggestive of a closed loop obstruction. And then there is the actual inguinal hernia. So you know when you look at these, it's going to be an indirect hernia if it's lateral to the inferior epigastric vessel, the inferior epigastric artery coming off of the external iliac/femoral. Right, so look at all that mesenteric stranding, and here the bowel loops come together, and we can see them go out that inguinal canal. It went out lateral to the inferior epigastric artery. And of course, if it heads then medially and down towards the scrotum, that's going to be an indirect hernia as well. There's the inferior epigastric, and there is the loop of bowel heading down towards the scrotum. So again, that definitively determines this is an indirect inguinal hernia. So again, closed loop obstruction, everything came together there, lots of mesenteric stranding, lots of wall thickening. So that is one of your more emergent inguinal hernias. All right. This is a strangulated inguinal hernia. So just as I was saying, they want to know every time when you describe a hernia, you say whether there is wall thickening stranding, fluid collections associated with it, and give them a thumbs up or thumbs down on this is or is not a strangulated hernia. So you can see we've got dilated small bowel. There's mesenteric stranding here as well, but the bowel in the peritoneum doesn't look so terrible. But look at this in the scrotum, loops of small bowel with wall thickening, mesenteric fluid, clearly strangulated, and should be reported as such. So there are your dilated loops of bowel, intraperitoneal fluid. And you can see again, this one's going lateral to the inferior epigastric artery, right there. Right? And it goes down into the scrotum. So again, that's going to be an indirect inguinal hernia. Most of them are, and especially in children, they're going to be indirect. All right? Nice view of that heading lateral to the inferior epigastric artery. The inferior epigastric artery actually loops under it and is displaced by it. Let's watch that one more time so you can appreciate that. Right there, loops under that hernia. All right, so this is a direct inguinal hernia. You can see the dilated loops of bowel there. And here is the hernia itself. You note it's on the medial aspect of the inferior epigastric artery, which you can just see to the lateral aspect there. Right, and this one does not head down into the scrotum, and it doesn't move significantly medially or laterally once it exits the peritoneal cavity. So that is a direct inguinal hernia. This is in older people, usually related to lifting. And you can see that bowel loop. There's the inferior epigastric, and then medial to it, there's the bowel loop exiting the peritoneal cavity. All right, let's look at that one more time. Direct inguinal hernia. All right. So this is a combination hernia. Sometimes you can get one that actually bridges the inferior epigastric artery. And that's what this will be. So we've got dilated loops of small bowel. You can definitely tell something's going on already. And here is what they call a pantaloon hernia. So half of the herniated bowel loop is going medial to the inferior epigastric, and half is going lateral. So it's a combination of direct and indirect, and it's just straddling that inferior epigastric, defying all definition. So here you can see it coming down and just looping around that inferior epigastric. So that is a pantaloon hernia with components of both direct and indirect hernias. Very nice. All right. Obturator hernias. These are not that common, and I'm glad to get the chance to point them out to you, because if you don't know they exist, you'd never find it. These happen in institutionalized patients, old, elderly patients, usually cachectic patients as well. It takes some degree of weight loss to allow a gap to be present in the obturator region. Okay, so dilated loops of small bowel. And then right here, sorry, psych, there's more dilated small bowel. Right here is your obturator hernia. It's going out the obturator foramen, and it will be lying under the external and internal rotators. It would be the, well, there's a mix there. There is an external rotator there as well. So there is the hernia sac, right, lying basically between the adductor musculature and the obturator foramen. So watch right there as it squeezes through, and then there is the obstructing hernia. And there is a significant degree of bowel obstruction, obviously, throughout the peritoneum. And you can tell, too, that this is an elderly patient, probably a nursing home patient, who's relatively cachectic, and that allows there to be space between the adductors for this bowel loop to slip. Okay, obturator hernia. So if you're looking at an old patient with a big dilated small bowel, don't forget to check the obturator foramen. All right, a couple other strange hernias. This one is just a lumbar hernia. These are often post-traumatic or post-operative, where there is a defect in the lumbar fascia. But this is one I like because it is a clear example of a strangulated hernia. There's lots of mesenteric stranding, thick-walled bowel sitting in that hernia sac, even though the obstruction isn't necessarily the highest of grades. That I would still call a strangulated hernia that's at risk for ischemia. Right? So that is a strangulated lumbar hernia.